Our next speaker is Dr. Gary Gottesman, who's a professor of pediatrics and medicine at Washington University School of Medicine. He's also a member of our scientific advisory board for soft bones. And yes, round of applause. And many of you may know him from his years that he spent working at Shriners Children's Hospital in St. Louis, where he worked with Dr. Michael White. And we're really thrilled to have him here to talk about the results, kind of a summary of our international scientific meeting last year. We had over 80 physicians and researchers from around the world gather in Maryland to really talk about the gaps in research and the latest and greatest of what we know about treatment, where we see research going in terms of new treatments. And so we thought it'd be great to share with you a summary of those presentations. So he's got a rapid fire set of slides to take us through it. So please join me in welcoming Dr. Gary Gottesman.
As Deb said, I've been tasked to present basically 2 days of lectures in 30 minutes, maybe a little more, thanks to Dr. Thicker, she ending a little early. This was the outline for the meeting, and so we're just kind of going to follow what we did a year ago in Bethesda. So the first talk was by Dr. Hogler, and he talked about the ALPL mutation database that's now, it used to be kind of taken care of by Dr. Mornay's lab, but with his retirement, it was taken over by Dr. Hogler in Austria. And it's a place where we can go like ClinVar and other databases, but this is specific for ALPL. And it lists all the known mutations, and then it relates them to the phenotype. So whether this mutation has been found only in adult or onset or only in autosomal dominant HPP versus more severe disease. And you can actually go through, and it has all the literature there, supporting literature. So if you want to find specific information about a single mutation, it's a great place to start, and it's free. And this is what it looks like when you get to it. And you can see here that the first one shows that it's been found in childhood, HPP. There's an example at the bottom where it shows that it can be asymptomatic, the exon 3 mutation there, but when found with another mutation can cause infantile disorder, infantile disease. The next talk was by Nilton Salas, a visiting rheumatologist from Brazil, who spent a year with us in the Division of Bone and Mineral Diseases on the adult side at WashU, but then spent much of his time at the Shriners Hospital researching all of our parents of the children we evaluated. And he noticed, just the broad-ranging variability of expression of this disease. And then went into really trying to characterize, okay, who's a carrier and who's affected. And so he used all the clinical, biochemical, radiological, and molecular analyses we had available on 174 families. So I've seen over 300 patients with this disorder, and now well over 200 families or so with hypophosphatasia, and continue to diagnose new families. In the findings of the 302 parents that were involved in this study, 130 were found to harbor at least one change in ALPL. 35% or 12% of the parents had no pathogenic variant, and then 137 had not yet had their analysis completed for ALPL. When looking at their clinical phenotypes, only 18%, or about 55 of the 302, actually had clinical features of what we would describe as hypophosphatasia. 46, or almost 47%, were unaffected carriers. So they had no clinical features of HPP except for some biochemical findings. So, a mildly low ALP, a mildly high PLP, and then they would have a pathogenic mutation on their molecular studies. And then 35% of the parents had no evidence of HPP, both biochemically, radiologically, or with molecular diagnosis. 196 of the patients, or 65%, did have lab findings, had biochemical evidence of a biochemical phenotype for a carrier, or they had a molecular change that we know might not cause disease, but might only cause disease when coupled with another variant. And those are the true carriers, where a single mutation that's located in specific areas of the gene doesn't result in a clinical phenotype. So the bottom line of Nilton's work was that a low alk phos, an elevated PLP, and the presence of a gene change does not make the diagnosis, no matter what the, what some of the other aspects of HPP in the community are. That I see a number of patients each year that meet all these criteria but do not have HPP and don't belong on medication. So I have, I think, taken as many people off of Strensiq, aspartase alpha, as I've put on in the last 8.5 years since it came on the market. So this is where it's, the art of medicine comes in, and it's tricky, especially in adults, as Dr. Deal was saying. So you really need a detailed clinical evaluation, laboratory studies, imaging studies, pedigree analysis, to really put everything together and decide who needs therapy and who may benefit from other options. Okay, let's see. Can you advance this to the next slide? Okay, then Dr. White went on to talk about the implications of positive findings in families. So there are repercussions, as Dr. Deal said, as Dr. Thickershey said, there are repercussions from just getting the diagnosis. First there's probably some disbelief if it hasn't been recognized in the family before. The parents may harbor some guilt for passing on something they didn't know they carried. And then learning that not only is the child at risk, but the siblings may be at risk, future children may be at risk. The parents now may be found to carry a disorder they didn't know they have, which may have implications for things like life insurance and other aspects. And then there's the crucial thing of, the grandparents who have osteoporosis, who have maybe starting bisphosphonate therapy, which is like adding gasoline to the fire when it comes to HPP. You're taking somebody who has too much pyrophosphate and giving them basically, bisphosphonates are pyrophosphate analogs, and potentially causing more problems than really helping them. Okay, now on to the next section. Okay, so Dr. Ferreira from the NIH talked about pyrophosphate. You can see a schematic drawing I put together of what pyrophosphate looks like. That middle little circle between the two is typically an oxygen. The bisphosphonate drugs I just spoke about all have, more recently, a nitrogen in that spot, which doesn't allow alkaline phosphatase to break it apart, and then plays a role in preventing resorption of the bone, and it's used to help people with osteoporosis. So this compound was first discovered in 1897 by heating sodium phosphate salt until it was red hot, and Pyro, I think, means red in Greek, so that's where the name came from. It was really started to be understood of its role in biological systems by the Coreys, I think at WashU in the 1940s. They won the Nobel Prize, I think, for the citric acid, discovering the components of the citric acid cycle. And it plays a role in, the biosynthesis of proteins, nucleic acids, carbohydrates, et cetera. And then there are a number of diseases where pyrophosphate plays a role, notably in HPP, where levels are too high and mineralization is poor. There's the converse with ENPP1 deficiency causing something called generalized calcification or arterial calcification of infancy. And that's where you don't have enough pyrophosphate. ENPP1 helps you make pyrophosphate. And so you can end up calcifying your coronary arteries as an infant. And this is often a lethal condition. And babies may even die in utero because their coronary arteries calcify. And these other disorders are associated typically with low levels of pyrophosphate and ectopic calcification. Dr. Wenkert gave an interesting talk about the phenome. So a phenotype is derived from the Greek word meaning to show or appear, and then the nature of that appearance. So our phenotype is how we look, in the clinic, or how we interact with our environment. And then the phenome includes sort of all the other aspects of who we are, what our environment does to us, what we eat, how our gut microflora interact with us. And so she went on to try and explain why we might see children from the same family with the same mutations whose phenome may be different between the two. And so why you can see one child with infantile hypophosphatasia and then maybe another child in the same family, same mutations, with mild childhood disease. And then she told a little bit about a mouse model where they deleted the alkaline phosphatase gene, but also deleted ENPP1, and those mice had no skeletal phenotype. So showing the interactions of multiple genes may play a role in how things get differentiated. Then there's epigenetic effects, things like inhibition of histone acetylases that may alter ALP expression. So that if you don't have enough of the acetylases, I think your alkaline phosphatase expression rises. We talked about the intestinal flora. They had mice where were never exposed to bacteria, and they have high bone mass, but then if you introduce bacteria into their gut, their bone mass drops to normal. So other factors where, HPP may be modified just by what goes on in our gut. Then she talked about some of these other issues. And then the other disorders that can have low alkaline phosphatase, so celiac disease, hypothyroidism. There's over 20 different disorders that can cause low alkaline phosphatase. And I kind of wonder in Fergus McKiernan's list from the Marshfield Clinic, how many of the low alkaline phosphatase patients in that group might have had low zinc or low magnesium or some of these other diseases. And it's been a while since I've read the paper, whether he really characterized them. And then how diet and exercise can also affect our phenome. Then Dr. McKee from Montreal talked about how biomineralization is marked by duality, that the default thing is not to let us mineralize anything, and that we have to, because if we would all just kind of turn to stone if mineralization could occur anywhere in the body. But then there are inhibitors that keep us from mineralizing everything. And then there are inhibitors of the inhibitors that allow us to produce mineral in our bone and wherever else it needs to be. So the default pathway is not to mineralize, and then by enzymatically degrading the inhibitors, we're able to put mineral where it needs to go into the bone. And then he described this stenciling principle and how different enzymes can get together and help process the mineral in our bodies and so that it goes into our bone and teeth, and showed an interesting figure. Now I don't have figures from the slides from last year, but I grabbed this from one of his publications, and he talked about how the collagen gets mineralized, and it's in this tessellated pattern. So another natural form of tessellation is, say, how bees make a honeycomb, and you get the hexagonal pattern. And so anything with repeated sort of polygon-shaped patterns can be called a tessellation. And he shows a diagram over here to the bottom right in just the black and white, where the fragments or tessels of mineral are placed on the collagen backbone and end up helping us mineralize the skeleton and harden it. Can we advance another slide? And one more? So then Dr. Manti from Arizona talked about pain in HPP, and he described, certainly fractures will hurt, that delayed healing of a fracture may actually prompt sprouting of new nerves in places where they don't belong that may cause the body to respond with pain, that wouldn't normally have occurred. He went on to talk about the contributions of not only joint pain, but muscle pain, and that the pain may not be inflammatory, but could indeed be neuropathic, and how treating neuropathic pain is much harder to treat than treating an inflammatory pain, where you can give things like NSAIDs and other drugs that might help a little more easily. Then I talked about the difficulties in making an appropriate diagnosis of HPP, and we've, previous speakers this morning have been through this list. Bone biopsy is sometimes necessary, which can help clarify, especially in adults where you don't know if you're treating hypophosphatasia or osteoporosis. They look very differently under the microscope with a bone biopsy. And then I talked about several complicated examples of things that will make it difficult to diagnose HPP. And again, the bottom line is that no single finding, not a low ALK phos, not a high PLP, not even a molecular finding, is enough to diagnose HPP. Dr. Tebben kind of reiterated that from the adult side, talking about osteoporotic patients. And again, if you have an osteoporotic patient who carries a mutation for HPP, do they have hypophosphatasia or do they have osteoporosis? And really the only way to differentiate that is with a bone biopsy, looking for evidence of osteomalacia, which is soft bones, or looking for the changes in trabecular structure where the webbing of the bone diminishes in osteoporosis, and it causes problems. And I had a patient, a year and a half ago, a woman came down from Chicago convinced she had hypophosphatasia, but her bone biopsy showed no osteomalacia. It was just classic osteoporosis. And I have had a 71-year-old man who presented last year. The common C1250 gene that mutation that you've seen on a slide here earlier today. He was walking 20,000 steps a day, selling motor homes, and was a former high school football player, big, strapping guy, 6'3". And at that time, I decided, I didn't think he really had changes that were consistent with hypophosphatasia. I had Bill McAllister, our 93-year-old radiologist, former head of radiology at St. Louis Children's, and who still works 4 days a week. And he looked at the man's x-rays and said, no, this is just normal adult degenerative bone disease. Well, then over the last year, this man's become much more debilitated. And he appeared in my clinic a month ago, and I said, we really need to understand what's going on here. His bone density is actually above the normal range. It's gone up in the last year without any therapy. Is that evidence that his osteomalacia is getting worse? And so he did consent to have a bone biopsy, which will be done at the end of the month. And hopefully I'll be able to differentiate some other bone problem from osteomalacia and hypophosphatasia. But if he has osteomalacia, I'm going to treat him. So it's complicated, okay? And Dr. Tebben then went on to also talk again about the risks of starting somebody with HPP who's been mistakenly diagnosed with osteoporosis with bisphosphonates. So again, that's a theme that runs throughout our clinical work. Okay, and then this was the slide I prepared to describe what Dr. Deal had done last year, but I think he's covered all of this already today, so I'm going to move on. Dr. Seefried from Europe described how each HPP patient needs an individual approach. Even within families, as we've said, you can't assume that just because one patient was mild, the next one is going to be similar. And so the genomic sequence may be the same, the changes may be the same, but what actually occurs in each individual may be different because of modifying genes, modifying enzymes and things. He then went on to describe a 2-year study he did, studying the efficacy of aspartase alpha. There were 22 patients in the study, 17 were female, and he showed that there was improved functional testing and quality of life during the 24 months these patients were studied on therapy. I think they all had to be on therapy for at least a year before they joined the study, but he was able to show continued improvement. And then he did an interesting study restricting calcium and phosphate in patients with HPP. The results weren't conclusive, but there seemed to be an indication that there was some improvement in some aspects of the disease, because most of you with HPP will have elevated levels of phosphate in your blood. You tend to resorb more from your kidney than maybe you should. So that there were only a handful of patients in that study, and that probably needs to be expanded upon. And then this was just to show you an example from my talk last year of 2 siblings a year apart. The one on the left has severe childhood or infantile hypophosphatasia. He was diagnosed before 6 months of age and needed craniotomy. And then his brother, who has mild childhood disease and did much better with Strensiq than the younger brother. And so it's been interesting how the same exact genotype, same mutations, but one had milder skeletal disease than the other. Trying. Okay. Then Brian Foster from the Ohio State University talked about how some patients with HPP may not really have any dental problems. Some may have a few, and then there may be extensive dental problems as described in the previous talk. And he just talked about the four main components of the teeth and saying that most of the problems in HPP originate with the problems with cementum, and the teeth are poorly attached to the bone, and which leads to tooth loss with the intact root. And then he talked about the different animal models that are being used around the country, and many people are from these labs are sending him the teeth for analysis, where he does all sorts of micro CT to analyze and other histologic things to look at the teeth and see how they change. The sheep model is very interesting because unlike mice who don't really shed primary teeth, the sheep do. And so they are providing newer insights into some of the dental issues with hypophosphatasia. Dr. DeMombro talked about fat metabolism and hypophosphatasia. So this came about because of the adverse effects that were identified with aspartame alpha in the clinical trials when we started to note patients with lipohypertrophy. And Catherine Madsen in our unit ran the clinical trials for hypophosphatasia there and was one of the first people to really report these findings about the fat metabolism. And Dr. White got Clifford Rosen interested, and then Victoria had worked with Dr. Rosen for years, and this became, I think, part of her PhD project. So the interesting thing is that bone cells and fat cells have a single progenitor cell, so they come from the same stem cell, and that there are high levels of tissue nonspecific alkaline phosphatase in fat cells along with bone cells. And they have been using both mouse and sheep models to study tissue nonspecific alkaline phosphatase in fat, and have found that if there's decreased function of alkaline phosphatase in fat cells, there's lower numbers of fat cells. And then they've identified a role for low alk phos causing problems with energy production, which may explain the fatigue that people feel with hypophosphatasia. So there's one specific mouse model where they've been able to really document not only decreased fat, but then decreased energy production and expenditure. So once again, we'll emphasize that HPP is more than a disease of skeletal mineralization. Dr. Rallo, an optometrist, studied the patients that we saw at the Shriners Hospital in St. Louis in one of the original Anobia trials that they started. I think they were 5 to 12 when started, and by the time they were done, the oldest was 16 years of age. 13 patients who he looked at the eyes and found that there was calcification of the conjunctiva and possibly the cornea in some of these patients. 4 of the 13 had no calcium deposits. 4 had deposits prior to starting Strensiq. So is this just natural history of hypophosphatasia, that some patients develop calcium in their conjunctiva? 5 developed calcification on therapy. So does that implicate the drug in causing calcification in the conjunctiva? And the bottom line is we don't really know. It may just be that that would have been the natural history of those patients even had they not started aspartase alpha. The bottom line is, though, none of these calcifications interfered with vision. So the children had normal vision. There were 2 patients in the study who had severe craniosynostosis that went unrecognized and had optic atrophy, but that was unrelated to the calcification. And then Dr. Rush gave a talk about describing phenocopies, things that other clinical disorders that look like HPP and aren't. And I would argue that very few of these things would be confused with HPP if you take the history and the clinical context and then your evaluation into consideration. The one that struck me the most likely, and happens not infrequently, is when HPP is mistaken for severe osteogenesis imperfecta in utero. And that's one where, again, they are a bit different, but it's not hard with just being able to do ultrasounds to mistake them. If you actually get a fetogram with x-rays, often you can differentiate them, but it's been years since I've done a fetogram to try and differentiate these things. And then lastly, we went into treatment of hypophosphatasia. And Dr. Eastal from Sheffield talked about the vagaries of using the normal range, that it varies from place to place and population to population. So he talked more about having a threshold where the changes occur that might lead to hypophosphatasia. And he said he used a low number of 43 international units per liter of ALP activity is where he starts to worry about hypophosphatasia. He talked about the utility of the ALP and the vitamin B6 level, the PLP level, and then went on to talk about how PLP can be interfered with if somebody's been on vitamin supplements that includes vitamin B6, that inflammation can change the levels of the PLP, and chronic kidney disease can also interfere. So you may mask or think you have somebody with disease that really may not. And then he talked about molecular testing being useful. Like Dr. Saul, I am a medical geneticist, and I think in this day and age, it's pretty hard to get, number one, get insurance companies to pay for therapy if you don't have a molecular diagnosis. So with the pharma-sponsored testing that's available today, we're often able to get testing for free, which helps. And so I am an advocate for, trying to make a molecular diagnosis in everyone. Dr. Tosi talked about the orthopedic interventions for pediatric hypophosphatasia, but noted that she's had to do far less in terms of trying to straighten limbs and fix things since the advent of Strensiq. And that's because we now can make a diagnosis in utero and embark on treatment as soon as some of these kids with more severe disease that might have required many surgeries and things in the future, but if we get them started on therapy early, they tend to grow straight and taller than they ever would have without therapy. She talked about how a common presentation for childhood HPP is presenting with pain, unexplained pain, and she went through a number of different cases, but again said that it's rare that she's had to do extensive surgery anymore for kids that are on Strensiq therapy. And then she emphasized just the need for a multidisciplinary approach to diagnosis and ongoing care. Can we advance the next one, please? Dr. Nunes from California first introduced this idea that now there's a treated HPP phenotype. So those patients with primarily infantile and severe childhood HPP who in the past would have been very different, but now because of Strensic have a totally different treated phenotype. He talked about the fundamental differences between pediatrics and adults, and then talked about the care wheel and how it differs between adults and children. And the wheel that Deb presented could be envisioned as a care wheel where each of the different spots along the wheel with a patient or in the center could have been all those things, you know, from the endocrinologist, the orthopedist, the speech therapist, to help at schools, you know, all the factors that go into caring for a child with HPP, and how useful it was to look at all these things and integrate them to help a child or parents and the child in the pediatric case. And then he described the difficulties of transition to adult care and talked about the NICHD's program that was started in 2020, trying to improve the transition of kids with chronic diseases into adulthood, and that we need to maintain the same level of care, preserve or improve level of function as they become adults, assure continuity of care, and then make sure that we've structured psychosocial support and work systems so that we can help these people, you know, have as normal a life as possible. Doctors Rockman Greenberg and Dr. DeHeer talked about patients who had stopped enzyme therapy and the implications it could have on them. So there were 4 subgroups. Those that were in the clinical trial, the adult clinical trial, and had to stop after the trial ended until the drug was approved. Patients that stopped because they didn't think it was working for them. People that lost access to therapy because their insurance changed. And then others that discontinued because of hypersensitivity reactions and things. And that this can any one of these things can lead to significant loss in the gains that are achieved while on the enzyme replacement therapy. They noted that there were demographic differences, that men seem to stick with the therapy longer and not discontinue if they had significant disease burden, while younger women tended to stop the therapy because they didn't think it was helping them, or some of the cosmetic changes in their skin bothered them. Many of them seem to have better mobility and fewer musculoskeletal problems than those that stayed on therapy. And then there were again, the reasons for stopping, the side effects, and changing jobs, changing insurance can complicate things quite often. And it's a battle from our end as clinicians to try and make sure you all can get back on therapy if you've changed, and one insurance company won't support, the new insurance company won't support it without a lot of prodding. And let's see. Next slide, please. Then Donna Griffin, a physical therapist who's probably seen as many patients with HPP as any physical therapist in the world because of her association with us at the Shriners Hospital in St. Louis, talked about how important it is standardized tests are used to measure functional deficits in patients with HPP, and determining do they have functional deficits or not? Do they really need to be on therapy? And then the crucial part is those that are put on therapy monitoring their functional improvement, which will then encourage the insurance companies to continue to pay for therapy because you've given them a rationale to continue reimbursing. She then went on to explain how these standardized tests and outcome measures can be tailored for each individual to get the appropriate measurements done. Then the last 2 slides are talking about prenatal gene therapy. So Dr. Matsumoto from Japan talked about a model that was mentioned by Dr. Saul, where they injected a vector carrying a bone-targeted gene for TNS-ALP, and that the drug was transferred into the mice at 15 days gestation. 7 of the 9 mice survived. All were seizure-free that survived. All gained normal weight, and their ALP levels climbed and was documented by histology to be active in bone. And then he went on to describe the difficulties of trying to transfer this to human fetal therapy. There'll be real challenges there, but does leave some potential for a cure. And then Dr. White went on to talk about the possibility of prenatal treatment, again, for babies, but talking about placental alkaline phosphatase and how it starts to be made about week 12 of gestation, and that there are instances where babies that are affected by maternal HPP start to improve in their bone structure as placental ALP is expressed later in pregnancy. But it's a bit confusing because we don't think the phosphate compounds necessarily cross the placenta. So how is maternal effects of placental ALP, which comes from the baby's genome? You know, the placenta is made with the baby's genes, but how does that then help the baby in utero? So there's still a lot of things to be worked out there. And then I just want to thank the Soft Bones Foundation for their devotion to improving the awareness of HPP and the medical care of children and families with HPP. And then just to show all of you, Deb had asked me, she knew I did origami, and I developed this, I give dollar bills to the kids at the hospital, and I developed this little hippo. And I'm hoping to get it eventually copyrighted and put up on the Origami USA website and charge people for the instructions of how to fold it, and then donate that money to the foundation. So I'm working toward that.